Hello. Welcome to the fifth session in our medical legal teaching series. My name's Alvin. I'm the medical legal lead at Mind the Bleep. And today, giving the lecture is Dr. Aditi Ranjan, who will be giving a lecture on overseas, sort of the legal foundation behind overseas visitors and interpreters, sort of practical information in regards to that. So before we get started, as always with these lectures, a few ground rules. This functions as a YouTube live for those who haven't previously tuned in. So you can post any comments into the chat and we'll have a look, and I'll ask Aditi at an appropriate time. With regards to feedback as well, we will have a feedback QR code at the end. So please feel free to fill that out. Okay, so that's pretty much all. So Aditi, thank you very much if you'd like to take the screen.
Oh, thank you.
Yeah.
So yes, I'll thank you so much for that introduction, Alvin. I'll just briefly introduce myself as well. So my name's Aditi. I am an academic teaching fellow, and I am also a trust grade doctor. So what I'll do is I'll start sharing my screen, and then we can get started with the presentation.
Lovely. And if people could let us know if they can't see the slides and so on. Okay, so adding to the screen.
So is my screen visible?
Yes, it's visible from my perspective.
Okay.
Yes,
Perfect.
I think we'll go ahead. All right.
Okay.
Perfect.
I am just going to switch my camera off. There we go. Yep. Is that still visible?
Yeah, that's visible.
Great, perfect. So I'll get started. Thank you everyone for coming to this presentation. So I'll be talking about the medico-legal aspects of seeing visitors from overseas and consulting with interpreters. So as a bit of a disclaimer, I just want to highlight that I'm not a legal expert, and the information that I'm presenting today is to the best of my knowledge, and it is based on current guidelines at this time. So I've made sure to make I've made sure that everything that I'm presenting is accurate, but if there is a very specific situation or something that's particularly complex that you're involved with, it's best to consult like any local guidelines that you might have for definitive advice. Okay, so just as an overview of what I'll be talking about, so I'll first start off by going over communicating in clinical practice, particularly when there is a language barrier present, when and how to involve interpreters, and some of the risks of relying on people who are untrained. And after that, we'll move on and discuss the NHS duties to overseas visitors. So this involves things like entitlement to care, the distinction between what is considered chargeable, what is considered not chargeable. And I think that this topic is actually quite relevant, but it's not something that's covered very often. I think there's so many languages spoken in the UK, and the UK is quite a popular tourist destination. And like from my own clinical work, I probably see a couple of patients every week who are from overseas and have been asked before about payments and what's chargeable. So having an understanding of the legislation and the guidance behind all of this is useful in clinical practice. So I'm going to start off with a case presentation. So in this scenario, you are a resident doctor working in ED. So a 62-year-old man from Portugal is visiting his daughter in London. So while he's on holiday, he develops severe back pain and he presents to ED with his daughter. So he doesn't speak English, but his daughter, who speaks both Portuguese and English, has offered to interpret. He seems to be in pain, but he is clinically stable. What should you do? So this is a an SBA. So I'll give everyone about 30 seconds to have a read of all of this. and put any suggestions in the chat. Video, is C, to use a professional interpreter, even if it delays the consultation slightly. So let's explore all of this in more detail. So I want to start off by looking at the statutory law, and also the professional guidance behind all of this, and they are both quite clear. So when patients face language barriers, it is the duty of the healthcare professional to make sure that they can understand and engage with their care. So, from the legal perspective, this is rooted in the Equality Act of 2010, which requires public sector organisations, which includes the NHS, to make any reasonable adjustments to make sure that individuals aren't placed at a disadvantage when it comes to protected characteristics such as race or ethnicity. And language can form a part of that barrier as well. So, where English proficiency is limited, making sure that the patient has access to interpretation services or translated information is considered a necessary adjustment. And failing to provide such reasonable adjustments can be considered indirect discrimination, particularly if a patient is unable to understand their diagnosis, the treatment options, or the risks involved with a particular treatment option. And this mainly has big like consequences for informed consent. So legally, consent has to be voluntary, but it also has to be informed. And if a patient can't understand what is being explained, then their consent to a treatment or an admission could be considered invalid. And this opens people up, clinicians and organisations, to both legal risk, but also negligence claims. And so the GMC's good medical practice is also aligned with this. And it states that doctors need to make sure that patients have information they need in a form that they can understand before they make decisions about their care. And the BMA has also echoed all of this, emphasizing that effective communication is essential for ethical medical practice, and that language barriers can undermine patient autonomy. So, consulting with a professional interpreter isn't just a good medical practice, it's also considered a legal and an ethical requirement to make sure that consent that is gained is valid and to protect patient safety. So, just to highlight, this is the quote from the GMC's good medical practice. So, it states that doctors must make sure that patients have the information they need in a form that is understandable to them before they make decisions about their care, and specifically states that doctors should make appropriate arrangements, which includes involving a professional interpreter wherever that's necessary. So, this really brings us on to the question of who is considered an acceptable interpreter. So, I will probably give everyone 20 seconds in the chat. You can post who you think either would be an acceptable interpreter, or anyone you think would not be considered an acceptable interpreter. So, I'll just give everyone a bit of time to do that now. Okay. So we'll start off by talking about who is considered an acceptable interpreter. And the gold standard really is a professional interpreter. So this is someone who is trained specifically to interpret within a healthcare setting. So professional interpreters are trained with knowledge of medical terminology, and they have also been trained with regards to being impartial and being making sure that conversations remain confidential. And we'll actually go over a bit more about interpreter training in a few more slides. But in a situation where a professional interpreter isn't available, a trained bilingual member of healthcare staff could be considered acceptable, but only if they've received formal training in medical interpretation. So being bilingual isn't enough. It's more about making sure that the person who is interpreting has been trained to interpret within a clinical context, and that requires specialized skills. Moving on to people who aren't considered acceptable interpreters. Um, so, family members are generally not considered appropriate, except where there's an emergency and there is no alternative immediately available. So, using relatives, especially spouses or children, can risk accuracy, it can risk confidentiality, and if you've got family members interpreting, they might put their own spin on things, and that can result in some sort of undue influence on the patient's decisions. Um, and this whole situation might make it difficult for patients to disclose sensitive information as well. Using minors to interpret is almost always unacceptable, except when there is a life threatening emergency. So children, depending on the age, might lack the medical understanding to accurately translate clinical information, and this can create very significant risks of miscommunication, especially when it comes to discussing sensitive issues. Legally, using a child as an interpreter can undermine informed consent and breach confidentiality, as children might not understand this and they don't have any obligation to uphold these responsibilities. So, professional bodies like the GMC advise against using children, except in a true emergency. But it is expected that a professional interpreter will be brought in as soon as possible. If you notice that children are being used inappropriately, heavily to translate a parent's or a carer's language needs, it can highlight a previously unrecognized young carer, or possibly also safeguarding concerns. So, in clinical practice, it's important to make sure that children aren't being used as interpreters. It can also be quite tempting, especially on a busy day or a hectic day, to use tools like Google Translate in an urgent situation. But these are not clinically accurate. They might mistranslate some key terms or nuances, especially when there's a complex medical discussion that needs to be had. They also don't account for cultural sensitivities. There's no confidentiality guarantees. There's a data protection risk involved with all of this as well. And y- the automated translation tools can't adapt the language that is needed for the person that you're speaking to. For example, if you're speaking to a child or a vulnerable adult, or like a specific emotional tone, depending on what is being discussed. So, even in a time pressured situation, it is often better to pick up the phone or use like a telephone or remote interpretation service than to rely on an automated tool. Okay. So this is a i- great chart. So um, having worked in places where patients come in with limited English proficiency, and sometimes you're not able to tell what language they speak, The NRPSI, so that is the National Register of Public Service Interpreters, have created this fabulous chart which identifies a language a patient speaks. So it's got the language in both the native script but also in English. And the patient can simply point to their language, and it allows people to quickly identify which interpreter is needed. And it's particularly good for situations where like assumptions based on the patient's like ethnicity or nationality might not be correct. It's worth noting that in some of the places I've worked, they have flag-based language identification charts. So whilst these can be helpful, it's important to recognize that they have some limitations. So, like one example I can think of is, for example, a flag of China to represent the Chinese language. However, this might not differentiate between Mandarin and Cantonese, which are spoken completely differently. Um, and so it can be useful to have a specific language identification chart such as this. So I just wanted to speak briefly about interpreter training. So qualified interpreters hold a diploma in public service interpretation from the Chartered Institute of Linguists. So this is a qualification, and this then allows them to register with the National Register of Public Service Interpreters, and members of this register have a strict professional code of conduct, which they must follow, and they are subject to disciplinary procedures if that code is breached. So, professional interpreters aren't just linguistically trained, but they've also been trained in confidentiality and cultural competence. And this is especially important because some patients might hold different health beliefs or have expectations that differ very significantly from us as providers. So, in these cases, using a trained interpreter can really help elicit the patient's ideas or concerns or expectations, and they are extremely helpful. So, in contrast, using untrained interpreters, whilst I mentioned this briefly earlier, they might summarize as opposed to translate accurately. They might omit sensitive details, or they might unconsciously or consciously impose some of their own views on the consultation, and that can impact the translation and the trust and also the clinical safety. Um, in the possibly rare situation where a family member has to be used to translate, um, it's important to perhaps set some ground rules and make expectations clear at the outset. So assigning roles and explaining to the family member what will be happening, and saying things like, "Can I ask you to interpret everything Mr. Ali says and everything I say as accurately as possible?" And giving a bit of a confidentiality reminder as well. In all of this, a patient is still welcome to bring a family member or a friend for advocacy purposes, if with patient consent, obviously. So, moving on to uh, how to practically consult through an interpreter. Um, so this is pulled from the guide for clinicians working with interpreters in healthcare settings. And so um, ideally, it's or the name and the ID of the interpreter should be recorded in the clinical notes. And during the consultation itself, we as healthcare providers should speak directly to the patient as opposed to the interpreter. So this can involve saying things like, "What are your concerns, Mr. Ali?" as opposed to asking the interpreter, "Please, could you ask Mr. Ali what his concerns are?" And this can help to maintain the relationship between the clinician and the patient, and it highlights the role of the interpreter as a facilitator and not a participant in the consultation. It's also equally important to avoid medical jargon when explaining things, but also to check the patient's understanding, and not just check whether something was translated. So avoiding closed questions like, "Do you understand?" And an alternative might be something like, "Can you please tell me what you understand about the treatment plan?" Might be better. Um, it's often important to keep in mind that consultations with interpreters take twice as long. So it's advisable to allow extra time when booking appointments, and rushing these consultations can lead to misunderstandings. And finally, it can be useful to add a language alert onto the patient's electronic record if they have one. And this flag helps other team members know which language a patient speaks and whether an interpreter is likely to be needed in future appointments. And I have previously had consultations where someone has seen a patient before me, put this language flag on, and when this patient came to me in clinic, an interpreter was booked in, and the whole consultation was so much smoother. So that was very helpful for me as a colleague. So I also want to talk about how to approach consultations with young people who might require an interpreter, particularly in the context of consent and confidentiality. So, Gillick competence refers to a young person's ability to consent to their own medical treatment without the need for parental permission or knowledge. And it mainly applies to children under the age of 16, and is normally based on whether they have sufficient understanding to comprehend what is being involved in that care. And it has been covered in a previous one of our medical legal lectures as well. And the Fraser guidelines are a specific set of criteria used for giving contraceptive advice or treatment to under 16s without parental consent. And it's basically around things like whether the young person understands the advice, whether they are likely to continue sexual activity, and whether they would be at risk of harm without access to treatment or advice. So even if a child is Gillick competent, it doesn't mean that they can necessarily interpret for themselves or for others. And language fluency and understanding are separate considerations. So using a child as their own interpreter can jeopardize informed consent and safeguarding. So it's better to use a trained and an impartial interpreter, especially if it's a sensitive discussion that will be had. Where the patient has an identified carer, so that's someone who gives them regular unpaid support, which is the national standard, the carer should also be provided language support to help with any clinical discussions, but this is only with the patient's consent. And this makes sure it can contribute quite meaningfully to a patient's care without breaching autonomy or confidentiality. So just to summarize this section of the presentation, so the GMC's Good Medical Practice Guidance has a strong emphasis on effective communication, um, and they recommend that reasonable adjustments should be made to make sure that patients are able to give informed and valid consent. In general, relatives shouldn't be used as interpreters unless there's an immediate life-threatening emergency where no professional support is available, because using family members introduces risks of omission of information or distortion or selective filtering. And it's better to use a professional interpreter for complex or sensitive conversations, as they can remain impartial, maintain confidentiality, and accurately convey information between a patient and a clinician. So, in short, using a qualified interpreter is considered best practice. Okay, so we are now going to continue with this case. So we are back in the emergency department, and with the help of an interpreter, you have diagnosed an obstructing renal stone, and our patient undergoes emergency ureteric stenting. He is admitted under urology and is discharged after 2 days. So you're getting all of his discharge paperwork ready, and he asks you if he'll be charged for his hospital stay. So, bit of a wordy slide. So, I will give everyone 30 seconds to read all the answers, assess, and post any answers in the chat. Okay, so hopefully everyone's had enough through all of these options. So the correct answer is C. He will be charged for his inpatient stay unless he provides a valid EHIC or a GHIC card. So let's explore all of this in a bit more detail. So, the legal basis for charging overseas visitors for NHS care is set out in the NHS Charges to Overseas Visitors Regulations 2015. And these regulations form the key framework that NHS organisations use to determine who is chargeable, what types of treatments are chargeable, and what exemptions there are. So, under these regulations, a overseas visitor is anyone of any nationality who is not ordinarily resident in the UK at the time that they are receiving the treatment. So this definition of ordinarily residence is quite key, and it is basically someone who is lawfully living in the UK on a settled basis, typically for at least 6 months, with the intention of remaining here. And this definition means that charges for NHS care isn't just based on nationality or passport type. It's based on settled status and how long someone has been living in the UK. So, for example, if you have a British citizen um, who is living abroad and they've come back to the UK for a short visit, they would be considered an overseas visitor and subject to NHS charges if they don't meet the residency requirement. So, in practical terms, it mainly affects who is asked for evidence of exemption. So, valid exemptions would include like an EHIC card, a documented refugee or an asylum seeker status, or proof of a reciprocal healthcare agreement. So, I would like to highlight that actually clinical staff are not responsible for charging decisions. It is important to be aware of the rules, especially when it comes to elective care or things that are not urgent. And it's more about knowing when to refer a patient to the overseas visitor team for eligibility checks. But I think the other main thing to remember is emergency care and immediately necessary treatment shouldn't be delayed while residency status is being determined. Um, and patient safety does indeed come first. So, understanding the legal definition of who is considered an overseas visitor helps us identify who is chargeable. Um, However, we need to make sure we balance this understanding with the need to provide safe but also timely care. So, when do these charges actually apply? So it's important to understand that the charges mainly apply for secondary care, and that's hospital-based services like surgery, inpatient treatment, and specialist consultations. But we will go into that more in the next slide. And whether someone is charged for secondary care depends on a few key factors. So, number one, are they ordinarily residents in the UK? If they are lawfully living in the UK on a settled basis, they usually won't be charged. Is there a reciprocal healthcare agreement? So some countries, like those in the European Union or the European Economic Area, have agreements with the UK that allow their citizens to access NHS care, either for free or for costs that will be reimbursed later using either an EHIC or a GHIC card. And finally, there are specific categories of exemptions as well, such as refugees, asylum seekers, looked after children, overseas students in the UK who have paid the health surcharge. Um, so, as I mentioned earlier, we don't make charging decisions as um, clinicians, but we do need to understand these principles and what is charged so that we can advise patients accurately. So, going into what is free and what is chargeable. So primary care is generally free for everyone, and that includes things like seeing a GP, most community services, walk-in clinics as well, but also family planning services. Um, but that excludes maternity treatments such as assisted conception or termination of pregnancy. Treatment at the emergency department is free up until the point of inpatient admission. After that, it is charged. Diagnosis of certain infectious diseases um, are usually free as well. So, vaccination for polio, diphtheria, measles, TB, MERS are usually free. And treatment required for physical or a mental condition caused by torture or female genital mutilation or domestic or sexual violence are also free. On the other hand, main things which are chargeable is inpatient care following emergency treatment, so an overnight admission, for example, following surgery, or elective procedures or non-urgent diagnostics are fully chargeable unless the patient has an exemption. So this brings us on to an important ethical but also a practical balance. So our duty of care as clinicians includes being compassionate and being respectful of human dignity versus the NHS's legal duty to recover costs wherever applicable. Because the NHS is a national institution, and it unfortunately is not a international institution. So our role as healthcare professionals is clear. We should always treat based on clinical need, regardless of the patient's ability to pay or the residency status. And whether you are providing emergency care or referral to secondary care, decisions should be made purely based on clinical grounds. Um, Responsibility is mainly with the NHS's overseas visitors team, who will assess the patient's residency status and determine whether any charges or exemptions exist. Um, so, our role as clinician is mainly in communication and consent. Uh, we have a role to be honest with patients and transparent about the possibility of charges, especially if they're going to be admitted or they're going to be undergoing treatment. And this forms a part of informed consent because patients not only need to understand medical treatment but any financial implications as well. So best practice is to make sure that overseas visitors are aware that exception to pay charges exist before they start treatment, and they can consider alternatives if they are well enough to travel. So, when it comes to us as clinicians, we have to ask ourselves a couple of questions. Firstly, is the treatment immediately necessary or urgent? Um, this distinction is important because immediately necessary care, like life-saving treatment or any care to prevent serious deterioration, must always be provided, regardless of a patient's ability to pay or their eligibility status. And it's vital to document the clinical reasoning behind why the treatment was considered urgent or immediately necessary. The second question is, have I ensured that the patient is not deterred from accessing care due to fear of costs. We shouldn't allow fear of charges to prevent a patient from seeking or receiving essential care. And the NHS guidance is also clear about this. And this means being sensitive with how we talk about charges with patients. Our role is to make sure that patients are reassured that the clinical needs come first, and that if their condition is urgent, it will be treated. But it comes with the need to balance patient safety with equity, really. So I wanted to talk a little bit about the planned treatment scheme, what's also known as the S2 funding route. And this allows patients who are ordinarily resident in England to access publicly funded medical treatment in EU countries, as well as Switzerland, Norway, Iceland, and Liechtenstein. Um, and this is strictly so to qualify, patients have to get approval from NHS England before they travelled. And one key requirement is that the NHS confirms that the treatment that they are receiving is within a medically and remaining within the NHS would constitute an undue delay. Um, And so, going through this application process involves submitting something called an S2 form, evidence of NHS GP registration, and proof of residency as well. And if it's approved, the NHS covers the cost of treatment, but some countries have a co-payment charge. Um, and this will basically allow patients to receive treatment that might be delayed within the NHS. Um, Important to note that the S2 is not available for clinical trials or for experimental treatments or for private care. So, I just wanted to highlight a few key take-home messages. So the first and foremost, emergency treatment should always be provided, no matter the patient's ability to pay or their eligibility for NHS care. The NHS has a duty to provide immediately necessary and urgent care without delay. Secondly, as healthcare professionals, it's not our role to assess whether a patient is eligible for free treatment. That task is the duty of the trained overseas visitors managing team or the administrative team. However, we have a role in identifying when treatment is clinically urgent and when care shouldn't be delayed. So, in short, we don't make decisions about eligibility or payment, but we do influence when it is delivered. Okay, so I think that's the end of my presentation. I welcome any questions, and here is a list of references I used for this presentation as well. Okay, so I'm just going to stop sharing my screen.
Lovely. Well, thank you very much, Aditi, once again. So very concise and comprehensive lecture covering, webinar covering both topics. And I think what was nice about it is not only covering the legal basis, but actually quite a lot of practical information. So very relevant to clinical practice, especially with the interpreters. So that was wonderful. I'm just going to put up for anyone watching. Here is the feedback link. So I think you can see the QR code there. It'll also be posted in the YouTube live as well in the comment section, as well as the description. So please feel free to give some feedback. Lovely. We'll just wait a little. Nothing so far in the questions bit.
No.
So yeah, just I think one important thing that you actually highlighted right at the start regarding the interpreters is without a proper interpreter or an attempt to communicate things effectively with, well, sometimes in emergency family members, it's the consent that's not valid. So
Yeah.
not communicating things and people not being able to weigh up options, and just you would have seen it. It's in your clinical practice. You go on the ward round, explaining some quite significant decisions, but people will just nod along because it's I guess more embarrassing to admit. Well, it's just easier to nod, isn't it? Now bear in mind that they may have very much not consented or understood or actually attained any of the pillars of consent. So getting for at least big decisions, getting a professional
Yeah.
interpreter is imperative.
Yeah. 100%.
Yeah. Emergencies, Aditi's discussed. And yeah, commonly held misbelief. The translation apps are not good, not good. Miss cultural news.
No.
And often, I'm not sure if you've used it for your, well, depending on what languages people speak, it does miss a lot, unless it's sort of
Mhm.
made, so, you know, French, German, so on, better. But there are far more languages in the world.
Yeah, and I think it's specifically for like medical like we get told at the start of medical school that, oh, when you come to medical school you're going to learn a whole new language. So how can we expect, because I think the tools are mainly for lay language, how can you expect them to translate medical terminology faithfully? And I don't know if I trust it 100%.
Yeah, exactly. So someone who's properly trained can ensure that proper consent is given.
Hmm.
And that's important. Yeah, I can't see anything in the comments section yet. So yeah, once again, please fill the feedback form for the purpose of the betterment of these lecture series. Yes, the next lecture will be in 2 weeks' time. I believe it's myself again, due to the delays. And we'll be having further lectures, webinars in September, October period as well. So please keep an eye out on CareerBook as well as Facebook. Lovely. Well, that's it from me. And thank you very much, Aditi.